Good morning. Can you hear me all right?
Yes.
So
Yes.
I'm Elvira Bramon, and I'm a professor of neuroscience and mental health at UCL. It's my pleasure to introduce you to Moushin. I've been very lucky to recruit a student like Moushin. She's absolutely brilliant. She's been very, very productive. She's in her second year and has already produced the paper from her PhD. She's getting ready for her upgrade. She's helping other students in the team. I mean, we're completely thrilled to have her in the team. And her PhD is focusing on using genetics to optimize the way we prescribe antipsychotic medications. And she's also going to look at, not today, but she's also looking at the health economics of pharmacogenomics. And she's going to present her very interesting work.
Thank you.
Moushin.
Would you like to share your screen?
Sure, thank you, Elvira. So I'll just share my screen. Give me 1 second. Okay, so hi everyone. As Elvira mentioned, I'm going to be sharing with you the study that we've been working on, as part of my PhD project. So I'll just begin by giving you some background. So currently, treatment for schizophrenia involves a trial and error approach in which patients undergo several cycles of antipsychotic drug therapy until improvements are eventually reached. So the patients are offered these standard doses, and this is only altered if the patient experiences an adverse event. And we do know that antipsychotics significantly improve the quality of life for patients. However, we do see a variation in the response and the tolerability to these medications among patients. So while some patients can improve significantly on a particular antipsychotic, others might show no response at all, or they might be experiencing adverse events with that same antipsychotic. So in terms of these adverse events, antipsychotics are associated with these extrapyramidal symptoms. So for example, we have tremors, involuntary muscle contractions, involuntary facial contractions, and some of these can be long lasting as well. They're also associated with a high risk of developing metabolic syndrome. So for example, weight gain, high cholesterol, high blood pressure. So ultimately, this approach can therefore lead to a low level of medication compliance and therefore a high rate of mortality in this patient population. One potential solution to this is through genetic testing. So after you take a drug, your body has to break it down and get it to the area that you want it to. And there are many factors that can affect this process and influence how you respond to that drug. So for example, we have age, we have sex, the environment as well, and of course we have your genetics. So of course, everyone's genetic information is different. So if we can offer a genetics guided approach, this can tailor the treatment to each individual to take into account some of these differences in drug response. So the variation in the response to antipsychotic medication can be partly attributed to these cytochrome P450 liver enzymes, also known as the CYP450 enzymes. And these enzymes are involved in drug metabolism. So for example, we have the CYP2D6 and the CYP2C19 enzymes, which are important in the metabolism of antidepressants and antipsychotics. So if we have genetic variation in these enzymes, this can then affect enzyme activity, which then affects the rate at which the drug is eliminated from the body. So as a result, the patients can be poor, intermediate, normal, or rapid metabolizers of these enzymes. So the main objective of this study is to develop a genetic intervention to guide the prescribing and the dosing of antipsychotic medication. And there are 3 main aims. So firstly, we'd like to see if this can reduce adverse drug events. And secondly, to see if this is cost effective for the NHS. And finally, we'd also like to gather some feedback from the clinicians themselves to see the value of this intervention. So here we have an outline of the study. So at the baseline visit, the patients provide DNA samples, and this can be blood or saliva. And they complete a questionnaire, which includes demographic questions, as well as clinical scales that are widely used in psychiatry. And the DNA sample then gets sent to an external lab for genotyping, and the results are used to create genetic reports. And the patient's clinician can then receive the report, which will include recommendations on drug selection and dose adjustments based off the patient's genetic profile. And now it's important to mention as well that the clinician can choose to follow these recommendations, but they also may choose not to. It's completely up to them. So the participants are then followed up at 3 months and once again at 6 months. And the clinicians will also be interviewed. They'll be given a questionnaire to evaluate their opinion on the value of this genetic test for their patients. And of course, the final step will be to analyze the data. So the participants that we've recruited from the study will be compared to a control group who've not had this genetic testing and have just had treatment as usual. And the two groups will be compared on key outcomes to determine the effectiveness of this intervention. And then we'll be analysing the clinician questionnaires and interviews to evaluate the acceptability of the intervention. And finally, we'll be doing some health economics analysis to see if this approach is cost effective compared to treatment as usual. So over the past year, we've been able to open 10 NHS trusts as recruiting sites, and we also have 2 which are in the process of opening at the moment. So we have just over 200 patients and 60 clinician participants. So this is almost half of our recruitment goal for the patients. And for the clinicians, we've already exceeded our recruitment goal, which is obviously great. And although most of our recruits have come from these recruiting sites, we've also received some self-referrals as well. And in general, the response to the study has been overwhelmingly positive. And it seems like there is definitely a demand for this type of service, both from the patients and also the clinicians themselves. So here we have a sample report which demonstrates, what the report may consist of. So this genetic report will be telling the clinician what type of metabolizer the patient is. So are they a poor metabolizer, a rapid or a normal metabolizer? And then it will provide recommendations on medication that the patient may take based off of this metabolizer status. And these recommendations will be in the format of a traffic light system. So green would indicate to the clinician to prescribe as usual. So this means that the patient can metabolize this medication at normal rates. Then we have amber or yellow, which would indicate a minor adjustment. So it might be worth monitoring frequently or potentially altering the dose. Then we have red, which would be indicating a major adjustment. And this would be telling the clinician that this patient would have issues metabolizing this medication and they may want to consider an alternative form of medication or alternatively a dose adjustment as well. And it's also important to mention as well that this is just an added piece of information. So just as the clinician would seek a medical history of a patient, we also just want them to factor in genetics when they are prescribing antipsychotics to their patients. So of course, it's really important that our sample is random and representative of the population. So for about 130 of our participants, we've had a look at their demographics to ensure that this is the case. So with regards to ethnicity, we have 68% of our sample who are white, 12% who are Asian or Asian British, 11% Black British, Caribbean or African, and 4% mixed or multiple ethnic groups, and 5% who identify as any other ethnic group. And then in regards to sex, the sample is almost evenly split. So we have 48% women and 52% men. And of course, as the sample increases, we would expect these proportions to stay roughly the same. So here we have the frequencies of the different metabolizer statuses for 176 of our participants. So if we look at the x-axis, we have several important CYP genes which are involved in the metabolic pathways of antipsychotics and also antidepressants. So you can see the patients are either poor, intermediate, normal, rapid, or ultra-rapid metabolizer. And there are also several patients who are identified as unknown metabolizers. And this means that they have a combination of alleles which is still not established how they affect the metabolism just yet. Then we have the y-axis, which includes the frequency. And in general, what we found was that the frequency of these normal metabolizers was definitely lower than the average population. So for example, if we look at CYP2D6, we see a higher frequency of these intermediate metabolizers who have a reduced enzyme activity. So the reason for this is still unclear, but what it could be is that it may be that our patients are primarily recruited from hospital wards, but they may be feeling more unwell compared to recruiting from community mental health services. We don't know what the exact answer is just yet, it's still quite early to say. So that's where we're currently at in terms of the study. So we're at the intervention stage where we are delivering the clinicians the reports. And the next steps are going to be to follow up with the patients and also the clinicians. And to conclude, we do understand that antipsychotic medication on the market does work. However, they just could be optimized. So what we're doing is we're developing this genetic intervention to guide the prescribing and the dose of antipsychotic drugs. However, genetics, of course, is not the be-all and end-all. It's just a tool that can be used to help clinicians understand more about the patients they are prescribing for. Thank you very much. And if you have any questions, please do let me know.